My presentation is on the Australian experience of measuring outcomes. What I'm going to do this morning is talk about outcome measurement, but I can't really unpack that from financing and case mix, so I am going to talk about the parallel developments in Australia of those two. You can't get incentives right in funding models if you don't take into account the outcomes that services get. Health outcomes, a change in a group or an individual that you can attribute at least in part to an intervention. So 3 key ideas. One is the idea that somebody changes. The second is the idea of attribution, which is really critical. This is not about health status. It's about health outcomes. The third idea is intervention, that something had to happen. And the clear idea is you can't measure health outcomes unless you can measure change, unless you actually can identify and classify the intervention, and you know that you can attribute it to one to the other. My next idea is that outcomes have to be linked to the goal of intervention. And this, I think, is really critical, particularly in areas like mental health, where no change can be a good outcome in some cases. The third is better or worse than expected, and that's actually, I think, a really key challenge for us. Is this person doing better or worse than we might have expected? And then the fourth, which is where you start to bring funding and outcomes together, is this is good value for money. So, some starting points based on our experience in Australia. The first is this one of utility, and that's that we cannot, and New Zealand certainly can't either, afford to collect data for only one purpose. And there's really some very good reasons to collect data, and there's some really bad reasons to collect it. The good reasons are because we actually want to use it when working with somebody. We want to use it as part of our screening or assessment or helping them navigate to get to the right spot. That's a really sensible use of data. The second is information sharing. People actually do want providers working with them to actually look like they know what they're doing and that they're talking to each other. The third reason is to help us set priorities, and the fourth is to account for healthcare. So the real trick, I think, for ministries around the world is how do you actually get data for your purposes, which is a byproduct of clinical care rather than an end in itself. We should be thinking about the system at various levels. So level 1 is impact and outcome for consumers, and here I'm talking about clients and carers and family and communities. Impact and outcome for providers at level 2, and then the third, which we're really bad at looking at, is system level outcomes. There's a hierarchy of measurement that flows from that, and most of our efforts, quite reasonably so, are at level 1. And we benchmark at that level. We do very little, and we do it very badly in terms of impact for providers. But clearly systems are only sustainable if they work at the provider level as well as at the client and consumer level. So what I've learnt in the last 30 years, that whether I look at cost, whether I look at quality, whether I look at outcomes, it doesn't matter what the metric is, I find significant variation that nobody can explain. And I really want to make a very strong point that variability is not good. It actually says that what happens to consumers is really random. If you go through one door, you'll get X, and if you go through another door, you'll get Y, and that is really inequitable. We need to be able to unpack those two ideas. We need to be able to identify how much of that variation is due to differences in the types of patients we've got versus how much of the variation is due to the way we treat people. So we need to be able to control in scientific terms for one cause in order to understand the other. And the reason that we need case mix classifications is because they're our way of controlling for the mix of patients. And if we control for the mix of patients, then the remaining variation we can say is due to providers, because it's actually the provider variability we're interested in, not the patient variability. And the implication, of course, is that if we were really smart about case mix, we would design systems which, as a byproduct, would help us better measure need and measure outcomes, because we could actually control for the mix of patients and then look at the outcomes that two services achieve and say, having control for the mix of patients, your service is doing better than yours. Why is that? And where we are in 2010 in both countries is that 18 years on, we've had 2 very large studies, one in each country, CASC and CHAOS, and we are still 18 years on, do not have a nationally adopted case mix classification in either country. And the issue for me, I think, in terms of mental health is how do we get sensible reporting if we can't case mix adjust? Is that the factors that drive costs are also measures of need and are also the best predictors of outcome. And from a quality improvement perspective, knowing about people's experiences actually tells you how you can improve rather than knowing whether they were satisfied. So I'm really pushing the idea that we should be moving towards thinking about outcomes and also thinking about measuring experience in a patient-centred way. And I've used the Picker Institute dimensions here as being the ones that I think are really important. We're never going to get the debate right in either country when we talk about cost rather than value for money. And we also want to move, as part of doing that, move the conversation from counting outputs and widgets and occasions of service to measuring outcomes and putting those two together. I think if you want to pay providers fairly and without creating perverse outcomes, you've actually got to take into account the outcomes that they achieve. And if you want to measure outcomes fairly, you actually need to take into account that there are a different mix of patients in each service, and you need to take that sort of case mix or the mix of patients into account when you're measuring outcomes.